Hi, my name is Alyssa, and this is Medisin, where learning is always in style. Today, we will be discussing a clinical approach to ischemic heart disease and acute coronary syndrome. By the end of this video, you will be able to outline the pathogenesis of atherosclerosis, differentiate stable, unstable, and Prinzmetal angina, differentiate STEMI and NSTEMI, as well as approach the management of each of these presentations. Before we start, make sure to like, comment, and subscribe. Also, follow our Instagram at MedisinStyle for more content on life as a med student and study review. Okay, let's get started. The coronary arteries are the arteries that directly supply the myocardium with oxygenated blood. This allows the myocardium to contract for each heartbeat. Unfortunately, some diseases close the lumen of the coronary arteries, which decreases blood flow to the myocardium. Without a consistent oxygen supply, the myocardium will not pump properly, and it may even die. Atherosclerosis is one of the main mechanisms by which the coronary arteries become occluded. Atherosclerosis is a buildup of lipid plaques in the inner walls of the blood vessels, or endothelium. Atherosclerosis is a slow process that is fueled by genetic and environmental factors. The first step of atherosclerosis is damage to the endothelium. Damage can be caused by anything, but hypertension and diabetes are common causes of injury. Next, the site of injury is infiltrated by low-density lipoproteins, or LDLs, and reactive oxidative species are made. Reactive oxidative species further damage surrounding cells. Moreover, macrophages infiltrate the area and consume the LDLs. The macrophages die, and the remnants remain deposited in the area. This forms a fatty streak. The damaged endothelium surrounding the fatty streak releases platelet-derived growth factor, which recruits smooth muscle cells. These smooth muscle cells secrete compounds like collagen that contribute to the formation of a thick, fibrous cap. The combination of the fibrous cap with the underlying fatty streak is known as an atherosclerotic plaque, or atheroma. Finally, the smooth muscle cells deposit calcium into the plaque, which hardens this plaque. Now we are stuck with a hard plaque on the interior aspect of our artery. This decreases the diameter of the lumen significantly. The quality and extent of occlusion of the coronary arteries leads to different clinical manifestations of ischemic heart disease and acute coronary syndrome. We will identify each clinical manifestation using three components: history, ECG findings, and cardiac biomarkers. For a review, check out our last YouTube video, Intro to Ischemic Heart Disease. Let's start with Stephen. Stephen is a 47-year-old male. He comes to his primary care physician because he has noticed chest pressure every time he goes upstairs or walks around his neighborhood. The chest pressure is relieved with rest. While sitting in the clinic room, Stephen has no chest pain, and his bedside ECG is normal. His serum cardiac biomarkers are also negative. This is the classic presentation of stable angina. Stable angina occurs when an atherosclerotic plaque has formed and occluded at least 70% of a coronary artery. At rest, the coronary artery is able to supply enough oxygen to the heart for normal function. However, on exertion, the heart must pump faster with more force to meet the demands of the body's muscles. The occluded coronary artery cannot adequately meet the heart's increased requirements. The myocardium becomes ischemic during these episodes, which leads to symptoms. Symptoms may include exertional chest discomfort, often described as squeezing, tightness, pressure, or pain. At rest, there are no symptoms. Thus, there is no ischemia, and the ECG will be normal. We must consider a cardiac stress test, which is an ECG that is performed while a patient is exercising. During exertion, Stephen's ECG may reveal ST depressions in the leads that correspond to the location of his affected coronary arteries. Since stable angina presents as reversible ischemia, the cardiac myocytes have not died. This translates to negative serum cardiac biomarkers. We can treat stable angina in the outpatient setting by managing risk factors and prescribing medications. Nitrates are vasodilators that can be used to relieve symptoms during episodes. Beta blockers decrease blood pressure and heart rate to decrease the oxygen demand of the myocardium, as well as prevent further development of atherosclerosis. Statins are HMG-CoA reductase inhibitors that manage dyslipidemia. Finally, aspirin and clopidogrel are antiplatelets used to prevent clot formation. Now let's consider Nancy, a 56-year-old female. She comes to the emergency department for acute onset chest pain that has not subsided with rest. Her ECG reveals ST depressions in the lateral leads. The resident gives her sublingual nitroglycerin, but the pain does not subside. Her serum cardiac biomarkers are negative. This is consistent with the presentation of unstable angina. Unstable angina occurs when the fibrous cap of an atheroma in a coronary artery cracks and exposes the underlying fatty interior. A thrombus forms at the site of the ruptured plaque, leading to acute ischemia of the heart wall. However, no cell death has occurred yet, which means the ischemia of unstable angina is reversible. For that reason, the cardiac biomarkers are negative. Like stable angina, the chest discomfort of unstable angina is often described as squeezing, tightness, pressure, or pain. However, in unstable angina, this discomfort is not relieved with rest alone. Since there is persistent reversible ischemia during unstable angina, the ECG will reveal ST depressions at rest or with exertion. Unstable angina can transform into a myocardial infarction if left untreated. This means the cardiomyocytes may actually die. Therefore, unstable angina requires immediate emergent treatment and inpatient monitoring to ensure there is no evolution into an MI. Treatment includes nitrates, antiplatelet therapy with aspirin or clopidogrel, and supplemental oxygen. Risk factor management may include beta blockers to lower blood pressure and heart rate, and statins to manage dyslipidemia. Now we have Preston, a 28-year-old male who presents to the ED in the middle of the night with new onset chest pain. On physical exam, he has dilated pupils. A bedside ECG reveals ST elevations in leads V1 and V2. He is given sublingual nitroglycerin and his symptoms improve. His ECG also normalizes. His serum cardiac biomarkers are negative. This is consistent with Prinzmetal angina secondary to cocaine use. Prinzmetal angina, also known as vasospastic angina, is a result of vasospasm of the coronary arteries. The coronary arteries temporarily constrict, leading to transmural inflammation of the heart wall. In other words, the entire thickness of the heart wall is ischemic. This may happen with or without the presence of atherosclerosis. Oftentimes, the vasospasm may be triggered by cocaine, alcohol, or triptan use. The sites of vasospasm translate to ST elevations in the location-specific leads. In Prinzmetal angina, the ischemia is reversible. Therefore, the ST elevations will resolve with the reversal of ischemia, and the cardiac biomarkers are negative throughout the process. Treatment includes nitrates for vasodilation and management with calcium channel blockers, as well as avoidance of the triggering agent. Now let's consider Stella, a 63-year-old female who presents to the ED with 2 hours of new onset epigastric discomfort, unprovoked by food or activity, and unrelieved by rest. An ECG reveals ST elevations in leads 1, 2, and AVF, and positive cardiac biomarkers. This is consistent with an ST elevation myocardial infarction, or STEMI. A STEMI is a transmural necrosis of the heart wall caused by irreversible ischemia. The cardiomyocytes along the full thickness of the heart wall have died because of inadequate blood flow through the coronary arteries. Oftentimes, STEMIs develop from a similar pathophysiology as unstable angina. The fibrous cap rips off an atheroma in a main coronary artery, leading to thrombus formation and occlusion of that major coronary artery. However, the end result is irreversible necrosis rather than reversible ischemia. Therefore, serum cardiac biomarkers are positive. By definition, STEMIs present with location-specific ST elevations in 2 or more contiguous leads. It is important to note that myocardial infarctions may present in a variety of ways. The classic presentation is crushing substernal chest pain that radiates to the left arm or left jaw, as well as diaphoresis. However, it is important to note that this classic presentation is most often found in men. Women can present with non-classic symptoms as well, which may include nausea, fatigue, dyspnea, and epigastric discomfort. Finally, we have Enrique, a 70-year-old male who presents to the emergency with a substernal chest pressure that radiates up his jaw. His ECG reveals ST depressions and T-wave inversions in leads V5 and V6. His cardiac biomarkers are positive. This is consistent with a non-ST elevation myocardial infarction, or NSTEMI. An NSTEMI is infarction of the subendocardial region of the heart, or inner layer of the myocardium. NSTEMIs are caused by occlusion of the coronary arteries, usually minor ones, by a ruptured atherosclerotic plaque. The necrosis leads to positive cardiac biomarkers. The subendocardial location of necrosis leads to ST depressions and/or T-wave inversions in two or more contiguous leads. NSTEMIs present similarly to STEMIs with substernal chest pain or pressure that may radiate to the jaw or left arm, diaphoresis, nausea, fatigue, dyspnea, and possible epigastric discomfort. Once the diagnosis of a STEMI or NSTEMI is made, management is extensive. Medical management includes oxygen, aspirin, nitroglycerin, heparin, beta blockers, ACE inhibitors, and statins. If the MI was triggered by cocaine, benzodiazepines are also given. A patient may undergo coronary angiography to better visualize the coronary anatomy and location of the occlusion. Reperfusion treatment may include a cardiac catheterization or percutaneous coronary intervention, or PCI. This helps reestablish the patency of the vessels if the symptoms of the MI begin within 12 hours. Complications include a cholesterol embolism or retroperitoneal hematoma. A coronary artery bypass graft, or CABG, is performed in 3-vessel disease, 2-vessel disease in patients with diabetes, or coronary anatomy that does not allow for a PCI. Fibrinolytic therapy is only reserved for patients who cannot undergo PCI within the next 90 minutes. Today we have discussed 5 cases with 5 different presentations of ischemic heart disease and acute coronary syndrome. Stephen had chest pain relieved with rest, ST depression on a cardiac stress test, and negative cardiac biomarkers, consistent with stable angina. Nancy had chest pain unrelieved by rest, ST depressions on ECG, and negative cardiac biomarkers, consistent with unstable angina. Preston had chest pain triggered by cocaine use, ST elevations on ECG, and negative cardiac biomarkers, consistent with Prinzmetal angina. Stacy had dull epigastric discomfort, ST elevations, and positive cardiac biomarkers, consistent with STEMI. And Enrique had substernal chest pressure, ST depressions, T-wave inversions, and positive cardiac biomarkers, consistent with NSTEMI. Our next video will address the possible complications and long-term effects of MIs, so stay tuned. As always, be sure to like, comment, and subscribe. Also, follow our Instagram @MedisinStyle for more content. My name is Alyssa, and this is Medisin, where learning is always in style.